Good afternoon, everyone. Can everyone hear me?
Yes.
Yes. Okay. Well, good afternoon. Welcome to the Diabetes Sisters Live Class webinar series on diabetes and heart disease. It's my pleasure to welcome you. My name is Anna Norton. Many of you know me. I'm the CEO of Diabetes Sisters. I'll also be moderating today's webinar. So if you have any questions, I encourage you to please use the question panel in your toolbar, and then I will reiterate those questions to Dr. Alexander at the end of the webinar. Like I said, today I'm pleased to welcome Dr. Sarah Alexander. Dr. Alexander is an assistant professor at Rush University Medical Center here in Chicago. She received her medical degree from Indiana University School of Medicine and completed her internal medicine residency and cardiovascular diseases fellowship at Rush University Medical Center, where she also served as the chief resident. She joined Rush University Cardiology in August of last year, is board certified in echocardiology, nuclear cardiology, and cardiovascular diseases. She spends most of her clinic time at Rush University Medical Center, and her research interests include cardiac evaluation in liver transplantation, echocardiography, valvular heart disease, hypertension, and preventative cardiology. Today's webinar will be focused on diabetes and heart disease, including the prevention and management of the disease. Please welcome Dr. Alexander to lead us the next half hour on diabetes and heart disease.
Okay. Thank you, Anna, for that warm welcome. So, as you know, today we're going to be talking about diabetes and heart disease, which is a very, very broad topic, and hopefully I can fit in some of the key points that are key to keeping in mind in your management and daily self-care, and leave some time for some questions at the end. So what exactly is the problem regarding diabetes and heart disease? So as many of you know, diabetes affects 1 in 10 U.S. adults, and 90 to 95% of the cases, the majority of the cases, are type 2 diabetes. And unfortunately, this is becoming an increasing problem in children. And the prevalence in children has increased by about 31% in the past decade, from 2001 to 2009. Accordingly, women with diabetes live an average of 8.2 years less than those without diabetes. Men typically live an average of 7 years less than those without diabetes. And diabetes is considered a coronary heart disease risk equivalent. So taking all that into account, heart disease is already the #1 cause of death in the United States for all comers, but it's also the #1 cause of death for patients with diabetes. So one question you can ask from this slide is, why is diabetes considered a coronary heart disease risk equivalent? Where does that information come from? So there was a study done in Finland back in 1998, and basically they looked at the 7-year incidence of having a heart attack among these Finnish patients, and they followed those patients for 7 years. They took patients with diabetes, here in the red, and patients without diabetes in the blue, and basically followed them for those 7 years. And they found that in patients who had a past history of a heart attack, over here on the left side, they found that in those with diabetes, they had a 45% chance of having a heart attack in those 7 years, compared to about a 19% chance in those without diabetes who had a prior heart attack. Now, if you look over here to your right, in these patients who have no past history of heart attack, and you separate them based on whether they have diabetes in the red or they don't have diabetes, you can see that patients with diabetes have a higher risk of having a heart attack in those 7 years that they were followed for. Now, what's concerning is if you look right here and compare, this risk of patients having a heart attack and they have diabetes is the same as those patients who don't have diabetes, but they had a prior history of heart attack. So it's a little confusing, but hopefully this graph here will show you that having diabetes gives you that extra risk of having a heart attack, and that's why we're very concerned. And patients with diabetes who present to a primary care office, they need to be followed a little bit more closely from a prevention standpoint. So bottom line, patients with diabetes and no prior history of heart attack have a similar rate of having a heart attack as patients who don't have diabetes, but do have a prior history of a heart attack. So what are the complications of diabetes? As many of you already know, these can be divided into microvascular complications, so diseases involving the small arteries. So what does that mean? So involving your eyes, or retinopathy, which is the most common. That's why you should be getting your dilated eye exams every year, or cataracts. Another is neuropathy, affecting the nerves, and that can cause tingling or burning sensations or even numbness. And that's why it's important to get your foot exam and your sensation checked in your feet, and to check for any potential wounds, because you want to avoid any sort of infection in the legs. And then the last thing is nephropathy, and that's just another name for kidney disease. And that's why you have the urine checked once a year to check for any protein that's spilling out, to make sure that the diabetes doesn't affect the kidneys as much. And actually, diabetes is the #1 cause of kidney disease in the United States. Now, all of these different complications, those risks of having these complications are proportional to how long you've had diabetes and how severe the diabetes is, which is why it's very important to be routinely following with your endocrinologist or your primary care provider to check your blood glucose levels, your hemoglobin A1C, etc. So we had talked about these microvascular complications. Where does heart disease fit in? So that goes under the category of macrovascular complications of diabetes. Macro meaning the larger arteries. So what does that involve? That involves coronary heart disease, or the heart arteries, and that can manifest just as a narrowing of the heart arteries, which may not be clinically evident, or it could be a heart attack that just happens. It could be peripheral arterial disease affecting the legs. So here is just kind of a schematic. It's very small, but you can see your whole circulatory system. So essentially, it can affect any of these arteries throughout the body. And then last but not least, it can affect the arteries in the brain or cause stroke. Over here on the right-hand side is kind of a longitudinal section of a normal artery where you can see normal blood flow. It's widely open. And then here's a little cross-section. And then in part B here, you see a narrowed artery with abnormal blood flow. And here in the vessel, the blood vessel wall, you can see the deposits of fat or atherosclerosis here. And in this cross-section, you can see the narrowing there. And that's basically what happens in diabetes that leads to blockages in either the coronary arteries or the heart arteries, or these peripheral arteries, or the arteries in the brain. So what are the things that we should be looking for every day when you do have diabetes? And even if you don't have diabetes, these are really important things to look out for. So #1 are lifestyle risk factors. So things that are within our control. Obviously, we can't control for our genetics, our family history, but there are lifestyle factors that are very important. The #1 being physical inactivity, especially in our country. A lot of us may have sedentary office-type jobs. Physical inactivity is a very important thing to keep in mind every day. Just getting up and walking around on your breaks, and when you get home, not watching TV, but getting up, maybe going to the gym or going to the park with your family. #2 is your diet. A lot of times at Rush, we talk about food as nutrition. You know, we think of medications as simply pills that we take, or pills in a pill box, or insulin, but food is also medicine, and we need to be really thinking about what we're eating. #3 is obesity, which goes along with our inactivity and our diet and our general overall lifestyle. And then #4 is smoking. And smoking, we won't go into it too much today because that's a whole other topic, but smoking promotes inflammation in the blood vessels, and it promotes the formation of blood clots, and it makes your platelets, which is your cells in your blood which promote the formation of blood clots, and makes those platelets more sticky and makes them kind of clump together and form blood clots. So that's why smoking can have a really detrimental effect on your whole cardiovascular system. And then besides these lifestyle risk factors, there's metabolic risk factors, so things that are measured in your doctor's office. So the first one being your blood pressure, which you will routinely get checked every time you see your doctor, also called hypertension. Number 2 is having high cholesterol, also called dyslipidemia or hyperlipidemia. And some people actually inherit a severe form of that, where they have very high cholesterol levels that are really tough to control. And then, of course, as you know, high blood sugar, diabetes. So another question and consideration we should look at is metabolic syndrome, which I'm sure many of you have heard of. And so metabolic syndrome pretty much encompasses these risk factors that I just went over. So in order to have metabolic syndrome, you need to have at least 3 of the following risk factors. And so those include a waist circumference greater than 35 inches in females, and greater than 40 inches in males. And then checking your lipid panel, your fasting lipid panel, or your blood levels of cholesterol. So what are those components? So we look at your HDL, which is considered your good cholesterol. And for your HDL, we actually want that level in your blood to be higher. So if we see a low level of HDL, less than 50 in females or less than 40 in males, then we're concerned because we want that HDL or good cholesterol to be higher. Another thing we look at are your triglycerides. So if your triglycerides are high or over 150 milligrams per deciliter, then we're also concerned. And then, as many of you already know, if your fasting blood sugar or glucose is high or over 110, that's another risk factor. And then finally, we look at your blood pressure. And one thing I tell my patients is when you're checking your blood pressure, make sure at your doctor's office that they're checking a second blood pressure. Because many times when we're rushing off to the doctor's office, we might be trying to find a parking spot, we're running late to the appointment, we're anxious and nervous about the appointment, and the blood pressure may be falsely elevated. So make sure that your doctor or nurse or assistant rechecks that blood pressure after about 5 to 10 minutes of sitting and resting quietly, and make sure the arm is at the level of the heart, and then recheck the blood pressure. A lot of times I see in my patients the blood pressure can go down by 10, 20, or 30 points just by relaxing and kind of taking a deep breath. So don't be alarmed if at your doctor's office you see that really high blood pressure. It may not be your true blood pressure. And then also it's good at home, or if you're at Walgreens, CVS, or local pharmacy, you can get your blood pressure checked using one of their machines. But I always tell people do it the same way every time. Make sure you're resting and sitting comfortably for 5-10 minutes, and that's the best time to check your blood pressure. And then this is just a picture of when you're checking your waist circumference of how to check it. All right, so in this backdrop of knowing what are all these little risk factors, what numbers are we looking for, we also want to know what are the mechanisms. Why does all of this cause heart disease? So it's basically the mechanism of chronic inflammation and injury over time. And so what this inflammation does is it activates the immune system, which leads to development of that fatty plaque in that slide I showed you earlier, where there's narrowing of the heart arteries or the arteries in your legs. And the platelets are also more sticky, which can promote the formation of these blood clots. So it all kind of works together to kind of create this perfect storm. And this is just kind of a busy slide for those of you who like your basic sciences, but these are all the different factors that come into play when we're looking at what causes heart disease in patients with diabetes. And so one of them is infection, which we don't really think about, but everybody should be getting their annual flu shot, because when you are exposed to infection, your defense mechanisms are down, you're exposed to bacteria and virus, and when your defenses are down, that can lead to increased inflammation, and over time leading to narrowing of the arteries. Also, we spoke of inflammation, high blood sugar, as you know, insulin resistance, and of course we always look at blood pressure, and then high cholesterol, and then thrombosis. Thrombosis just means formation of the blood clots, as we talked about with those platelets being sticky. And so that leads to what we call subclinical atherosclerosis, or subclinical development of that fatty plaque and narrowing of the heart arteries. So what do we mean by subclinical? That just means disease is there, but it's not readily detected or easily seen. So if a doctor examines you, they may not see the signs or symptoms of the disease yet, or you may not feel any symptoms of the disease, but it is there. So that's what we mean by subclinical atherosclerosis. And then over time, as we let these risk factors of high cholesterol, high blood pressure, unchecked blood sugars, inflammation and infection go on, the disease will progress to the point where you actually see events happen of heart attack and stroke, which is what we're trying to prevent here. So what can we do? And so it's not all doom and gloom. There are things that we can do. This is more just to give you an awareness of what's out there. What are the things that we should be mindful of? So we can take action. Number one way to take action is to know your numbers. So knowledge is power. Number one, know your hemoglobin A1C. So I'm sure all of you are aware of this. This is the average of the blood sugar that's in your bloodstream over the past 90 days or 3 months. And typically that goal you're aiming for is less than 7%. But obviously you should go with whatever your endocrinologist or your primary care doctor who is managing your diabetes recommends. The next thing is to check your fasting lipid panel. So this includes your LDL, which we call the bad cholesterol. We want that to be less than 100. Your HDL, which is the good cholesterol I mentioned earlier, we want that to be above 50. And then the triglycerides, we want that to be less than 150. And then we need to know your blood pressure. The American Diabetes Association recommends a blood pressure less than 130/80. As a cardiologist, we actually recommend it being less than 140/90. But either way, knowing what your blood pressure is and knowing that it should at least be around 130/80 or less is important. And then, of course, your weight and your body mass index. So your goal is less than 25. And then finally, know your past. Learn from your family history. Remember that your parents, older brothers and sisters, they're the ones who can show you the path ahead and what you may have to look forward to. So if you're seeing them go through something, it's important that you know about that. Ask the questions. Ask what age they started having a certain medical problem, what they did, and that way it informs you about the questions you should be asking your doctor, any preventive measures that you can take to avoid letting that happen to you. So number two, write it down. So it's very important to take inventory and take stock of where you're at. So very simply, keep a food log. There are many apps out there you can get on your iPhone or other smartphone of choice. I'm sure many of you have heard of MyFitnessPal or Lose It. It's a really easy way to kind of write down what you're eating. It'll actually save the foods that you commonly eat, and it kind of pulls from all different grocery stores and brands, so you can find almost anything that's out there. And then you put in your portion sizes, like a cup or an ounce or however much of it that you're eating, the time of the day you're eating, and it'll also give you a breakdown of fats, proteins, carbohydrates, etc. So it's a really good way to look back and say, okay, this is what I'm eating, this is when I'm eating, this is my total calories and the breakdown, and where can I make some tweaks and changes that's practical for my lifestyle and makes sense. The next thing is to note your triggers for eating. So what time of the day are you eating, and are you actually hungry at that time? Are you feeling stressed? Are you bored? It's just very important to be mindful of why you're eating. And then the big overarching question is, why am I doing this? Why am I doing any of this? why am I so worried about my lipids and my weight and my blood pressure? It's really hard, especially if you're not in the medical field or if this is something that you're not always thinking about, that what is the point of all of this? And so you need to think of that for yourself, whether it's for you, for your family, to be a role model for your kids, whatever that is, think about why you're doing this so you have a motivating factor that you can focus on every day to keep you centered and focused on your goals. So the next piece, number 3, is to get moving. And you knew I was going to mention this one, but the goal is to reduce your body weight by 7 to 10% in the first year. Obviously, if your BMI is already less than 25, you don't really need to do this, but you do need to do regular exercise. That's important for any of us. We recommend at least 30 minutes of moderate intensity exercise, at least 5 times a week. So that means getting your heart rate at 50 to 70% of your maximum, and that can be very simple things like taking a walk around the neighborhood, doing housework, playing with your kids, walking the dog, going to an exercise class. Whatever fits your lifestyle and your interests is what's important, what's going to get you there. And then a big thing, and this goes along with writing it down, is to make a schedule. And keep your gym clothes and shoes in your car if you drive to work or wherever you go, so that you're always ready. Because at least for me, if I don't keep things in the car, I'm not going to go. I'm just going to go home after work and you won't see me at the gym. So that's just something to keep in mind, what's going to make it a habit for you. That's actually number 4. So mind your mouth. So keep it natural. Avoid canned foods, deli meats, red meats, cheeses, processed and packaged foods. And I know that sounds like I'm telling you you really can't enjoy your food, but that's not true. We're just saying eat more fruits, vegetables, unsalted nuts, and fish. Reduce that intake of saturated and trans fats, and aim for no more than 2,400 milligrams a day of sodium, because sodium is really what drives water and keeps water in your body and increases the blood pressure. So sodium tends to hide out in these various packaged foods and processed foods. So look at your nutrition labels and just keep an eye on that. And then make more meals at home. And then another thing to consider is your daily intake of alcohol. So it actually could be 1 drink for an adult woman and 2 drinks for men. And so 1 drink is just a glass of wine, 12 ounces of beer, or about an ounce of liquor. So just something to keep in mind. And then get your family involved, because obviously if you're the only one in your household who is taking on all this, it might be a very hard plan to stick with. So trying to get some allies, somebody in your home or friends to get along the ride with you would be very helpful. And take your medications as prescribed. So I can't be a cardiologist and not say take your medications and keep up with the doctor's visits. It's very important that if you make any changes in your medication for any reason, if there's side effects, that you write those down and bring that up with your doctor, because it's always a partnership with your physician, and you should always feel free to ask questions and raise your concerns with them. And with diabetes, you should ask your doctor if you would benefit from a statin or cholesterol medicine or aspirin. These are two very important medications to consider taking when you have diabetes, and that decision should be made upon discussion with your doctors. So here's a risk calculator that I'd like to bring to your attention. It estimates your risk of having heart disease, heart attack, or stroke in the next 10 years, or your lifetime risk. This is the link. It'll be available if you want to look that up on your own. But you don't use this calculator if you've had a heart attack or stroke in the past, and you don't use this calculator if your bad cholesterol or your LDL is over 190. And so this is example 1 I have of a 45-year-old woman with no risk factors. So she does not have diabetes, she's not a smoker, she does not have high blood pressure, she is Caucasian. And then if you look up here, her 10-year risk of having a heart attack or stroke is 0.5%, the same as someone with optimal risk factors. And their lifetime risk is also the same. So this woman would not be in a statin benefit group, meaning they do not qualify to take cholesterol medicine. In my example number 2, so you have a 45-year-old woman with diabetes and no other risk factors. So by just having diabetes alone, you increase that risk from 0.5% to 0.9%, and your lifetime risk from 8% to 39%. And in this patient with just having diabetes, that's the only difference between this patient and the last one, they should get a moderate intensity statin. So this is something when you have diabetes and you're between the ages of 40 and 75, you should really be discussing with your doctor. So a big question is, should I be taking an aspirin? So per the different organizations, they do recommend a low dose or baby aspirin, 81 milligrams a day, in adults with diabetes and who have never had any sort of heart disease, but they have an increased 10-year risk of over 10%. Of course, you have to also balance that with your risk of bleeding. So this is, again, something you should be discussing with your primary care doctor. And then I just want to bring to your attention, Mayo Clinic has this website, which I encourage you to use with your doctors. They have a statin choice decision aid and also an aspirin decision aid, which can help you decide if this is a good idea and works for you. Last thing I want to talk about is coronary artery calcium. So this is also called a CAC scan or a heart scan. This does not require intravenous contrast. No contrast is needed in the veins. It's a simple CT scan of your heart arteries, and it looks for the presence of calcium. And calcium in the heart arteries is a marker of fatty plaque or atherosclerosis in the arteries. And this is a heart that is normal. This is the coronary artery or heart artery, which is open with no calcium, and this is the heart artery which has calcium. The white that you see here is a calcium, and that is a marker of fatty plaque. And the only reason we sometimes recommend this is for patients who don't know whether they should be taking an aspirin or a statin or cholesterol medicine, or they need that extra push to decide, should I be doing these lifestyle changes? Then we recommend getting a CAC scan or heart scan. So that's just something else to consider and bring up with your primary care provider. So last but not least, I have to say, please stop smoking if you do. There are many helpful resources, including your doctors and these various websites from the CDC. And then quick tips, habits are key. This is a lifestyle change and knowledge is power. Please don't be afraid to ask for help. And then these are some resources for you. Thank you for your attention.
Thank you. Thank you so much, Dr. Alexander. We actually have a couple of questions, so I'd like to just present them to you. The first question is, you mentioned in your in a slide about the risk factor of having diabetes and taking a statin, but we have a follow-up question to that. Is someone who has well-controlled type 1 diabetes also considered a risk factor for coronary disease?
Yes. So, you know, there are some studies. So that East-West study I showed, it basically said that it is a heart disease risk equivalent. But even if you have well-controlled diabetes, that's still someone who is at higher risk. Obviously, your risk will be lower, and that's an excellent question. But this is someone who I would still want to closely follow, make sure we risk stratify. So we're checking the lipids, the blood pressure, the weight. We're exercising, but as long as we're hitting all those points that I mentioned, then that person is in a very good position to prevent heart attack or stroke down the line. So I think with diabetes, we just have to keep in mind that we're going to be extra vigilant about looking at these risk factors.
Okay, thank you. The next question is, when it comes to diabetes and heart disease, does the type of fat I choose to eat make a difference?
Sorry, could you repeat that again?
When it comes to diabetes and heart disease, does the type of fat I choose to eat make a difference?
Oh, yes. So as I said, the saturated fats and the trans fats are the ones that we want to avoid. There are good fats like the omega-3 fatty acids found in fish. Those are good, but we want to avoid the saturated and trans fats.
Okay, the next question is, it says, I've read that some statins can actually increase blood sugar. Can you discuss this?
Right, so that's a really great question and one that we get asked often. So this is like a chicken and egg question because a lot of times the reason why I bring up all these metabolic risk factors like high blood pressure, cholesterol, etc., is because diabetes runs concurrent with all these other risk factors, especially with type 2 diabetes. So, you know, overall, it's a risk-benefit thing. So statins have been shown to improve mortality and to prevent heart attacks and strokes. So overall, the net benefit far outweighs any risk. And I think these have been very small studies that really have not shown, have really come to fruition in like a causation, like actually causing diabetes or worsening diabetes. So this is not actually something that prohibits me from starting a statin in anybody.
Okay, all right. The next question is, how do you know if you have calcification in the arteries? Does the doctor check this for this?
So that's where the scan comes in. So that coronary artery calcium scan or CAC scan, basically they do a quick CT scan of the chest and focus it on the heart. It doesn't require any iodine contrast, and they can see if there's any calcium in there. And you basically get a score. Some people can get a score of 0, which is fantastic, and but some people with higher scores, they may need more risk factor modification, more intense care.
Okay, and for those of us who don't visit a cardiologist regularly, would we mention that to our endocrinologist or to our general health care provider to refer us to receive this kind of test?
Sure, yeah, that's a great question. That's always something you can bring up with your primary care provider or your endocrinologist or whoever you see most of the time. Unfortunately, I don't think the CAC scan is covered by insurance, which is unfortunate, but there are places which offer it at affordable prices. It just depends on the community you live in. But if you're already taking a statin and you're taking care of yourself and all your risk factors are optimal, then you may not need to get a CAC scan. It really just depends on if it's going to push you to be taking an aspirin or a statin, etc. So it's very patient specific, but involves a conversation with your doctor.
Thank you. Now, this is the last question. This person says, I had a series of mini strokes in 2009. What is the risk of having another stroke?
Oh, that's a tough question and a good one for a neurologist. I don't think I can, what is the word, appropriately answer that question, but, you know, I guess you can use a quote, history begets history, like, you know, if something happened in the past, it could happen in the future. I would touch base with the neurologist and make sure, like, all the risk factors we talked about in the presentation are things that you're watching and you're taking the medications as prescribed by your doctors.
Okay, thank you. Thank you very much. So before we sign off, I want to thank Dr. Alexander again for this very informative half hour to all of us. For those of you who would like to see the slides again, we will have the audio and the slides available on our website at diabetessisters.org tomorrow morning. We'll also link it to our different social media outlets. So if you follow us on Facebook or Twitter, you'll be able to link to that directly. I want to thank everyone, as I always do, for registering and participating in today's webinar. Over 50 people registered, and we took all those registered names and entered them into a drawing for a copy of the American Diabetes Association's book, Diabetes and Heart Healthy Meals for Two. Today's winner is Diana Burton. Congratulations, Diana. I'll be contacting you very soon to send your prize, and I hope that all of you will join us next month on Wednesday, March 22nd at 4 p.m. Eastern Standard Time when we lead another webinar on diabetes and hormones. Thank you again for tuning in. Have a great afternoon.